get the whole story.
Redirecting patients to their own facilities. They tell you, no, you see here, you will pay this amount of money, but if you come to my facility later on in the afternoon, I'm going to charge you this amount of money.
If a clinician will be seeing patients in their own private facilities, outside, that is within their working hours that they should be in that public facility, that is unethical, and that is a disciplinary issue.
For a while now, Kenyans have been complaining about being redirected to private facilities for medical services. In some cases, if not most, these facilities are owned by the very doctors working in public hospitals or their colleagues who refer them.
The client has a right to choose where to be treated from. So in the event that they are asked to move from one facility to another, they have a right to ask questions on why that needs to be done.
KTN News posed this question on the provision of healthcare services by the medics in both private and public sectors via Facebook. The feedback was overwhelming. We received more than 500 responses, with most people narrating their experiences. For Maggie Almasi, hers was not rosy. She says she was redirected from the hospital of her choice to the doctor's private facility to get the needed medical attention.
We need to call them out. Those who are leaving their place of work and leaving their patients in the public service where they have been employed, not attended to, and go elsewhere to make money, whereas they have not done good for what the employer pays them, that then is another person that needs to be disciplined.
Redirecting patients to their own facilities. They tell you, no, you see here, you will pay this amount of money, but if you come to my facility later on in the afternoon, I'm going to charge you this amount of money. That is unprofessional conduct. That in itself is just outward conflict of interest.
Her experience is not news to many Kenyans.
When a doctor, knowing too well that there are drugs that are being sold at their facility, redirects a patient to go and buy the same or similar drugs to another facility, which this doctor either owns or has some ownership rights in that facility, that in itself is open conflict of interest.
There are many sanctions that can be taken depending on the level and type of complaint that we have received. We can have ranging from suspension of licenses, suspension from the register for a certain period. If it is very, very gross, that would even amount to a crime. It can even lead to deregistration.
Well, doctors have received some choice criticism over this, with most Kenyans drawing lessons from their own personal experiences to craft a perception.
If a clinician will be seeing patients in their own private facilities, outside, that is within their working hours that they should be in that public facility, that is unethical, and that is a disciplinary issue.
Some are criticizing the doctors, while others argue that according to the years they have invested in their skills, it is only fair for them to enjoy the fruits of their investments.
Patients actually used to ask me, Daktari, where can we find you next time in your own private facility? And the reason as to why they do this is because of the environment. Most of the private, public facilities, the environment is not very conducive. You find probably one or two nurses. The reception is not very kind because the people you are finding are fatigued. After you go through that, then there are waiting times. On average, if you go to a level 5, level 4, on average, you might spend around 4 to 6 hours just waiting to be seen.
Public hospitals are run by taxpayers' money. They are therefore required to be accessible to all Kenyans at all times.
We recognize the fact that we are not enough employed in the public facilities, and that if we were enough, then that would mean that actually nobody would open a private facility. You cannot open a business where whatever you're trying to address has been addressed, because you're not going to get any customer. You're actually closed down. When the demand is so high and the supply provided by the public facility is not adequate to meet that demand, then that supply, an equilibrium has to be sought.
Me, everywhere I've gone, I've
Christine Sadia is a retired medic. She was also an assistant director of medical services in Kenya in 1992. She recalls how it used to be done in her times.
When I went to health administration as even assistant director of medical services, that's when I got to understand the reason why it was. That is the time when we brought in the part-time private practice. Why was it brought? It was brought because that time, I will give you an example of a pediatric cardiologist. There was only one. The pediatric cardiologist was Dr. Assessor, and it was only one, and he was working at Kenyatta, seeing all the children being brought to Kenyatta National Hospital as the only referral hospital there. The director as the registrar, but also looking at the greater good of all Kenyans that they are served and given services, will then rationalize and say, give me your itinerary where you will be working. You had to give a roster where you will be at what particular time, and at that particular time, that is what is attached to your license, is taken to the board, they are approve it, the normal approval process, you are given part-time private practice.
We now provide that license and let employers and employees, who in this case will be doctors or dentists or health officers, to agree on the working arrangements that they will want to have. So our licenses do not prescribe the type of work one will be able to do. It only provides the skill that one can be employed at. That is either as a general practitioner or a specialist.
Sadia worked as a public health specialist in the Ministry of Health for more than 12 years. She paints a picture of how doctors who held private licenses used to be called on duties.
When you are called, we used to operate what we call a blip, and they used to come from Kenya Post Office. We were given like a pager. So you are paid. Kenya Post Office, Mata would call Kenya Post Office and said, we need Dr. Seto urgently, or we need Dr. Sadia, where urgently. So and at the same time, maybe the matron in Aga Khan has also called you, Kenyatta Hospital wants you back because there's an emergency. You had to talk to these primary caregivers and find out what is the state of this person, what is the state in your hospital. Then as a doctor, you have the difficult duty to decide who are you going to save first. Then you look at where the risk is high.
Sadia argues that it's not the doctor who is at fault, but the employer who should be held accountable.
The HR function, they also need to kick in. Yeah? When you are saying doctors are running and making money, that a person has come to a public facility and they have not found a doctor, who is supposed to ensure and track where that doctor is? Because in the scenario where I was telling you before a doctor was going to Mata, his primary place of work, like Kenyatta, he must have already left a message with either the director, I have been blipped, I'm going to Mata. Somebody or a matron knew where that doctor was and where they were going to function. So should they be needed, they will be found.
Right Honourable Speaker of the National...
With the Conflict of Interest 2023 bill currently in Parliament, medics are an apprehensive lot.
If that bill is presented and it, in the fullness of time, becomes law, and there is the incentive, as has always been the case, then there is no problem. You will need probably to ask for permission if you've taken the incentive of non-practicing allowance to go and act or be of service to another facility. But if that incentive is not provided to the professionals, then there will be nothing that prohibits them, either by that law or that bill being ascended into law or by any other reason whatsoever.
Issue of access will kick in, and the people who will suffer the most are families who are poor, who do not have out of pocket. Because, you know, right now, even as we speak, those who have money, some of them are already in their jets. They have gone to UK, they have gone to India. Who suffers? The people, the household with no money to go to India, to go to private hospitals, because that is where the public is supposed to be helping. And in fact, if you ask me if I went to health administration now, I will insist that the place where the 80% of Kenyans need to access care will be public service. This issue of privatization of healthcare, I think we need to wait.
The bill was introduced by National Assembly Majority Leader Kimani Ichung'wah and was passed by the National Assembly and sent to the Senate for further consideration. This legislation aims to change Kenya's approach to potential conflicts of interest within the public service, if and when passed, to replace the Public Officer Ethics Act of 2003 by providing robust guidelines for managing situations where private interests intersect with public duty.
When you are coming up with the policy documents, you should ask yourself, does it advance patriotism as a value and principle of governance? You cannot now take away, even it's not even in the public interest for you to take away the services of a doctor and to give that service to one professional, one employer to fully enjoy the services of this one professional. It is not possible for you to employ a professional. You can't claim that you have fully employed a professional. It is not possible. What you do, or what employers do, they think they have employed you, but what they do is that they compensate your time.
We need to put money where our mouths are. If life is important for Kenyans, let us invest into health sector.
Clause 23, Section 3 of the bill forbids a public officer from engaging in any other gainful employment without permission from the reporting authority and a graft agency, Ethics and Anti-Corruption Commission, EACC. It reads, a public officer shall not engage in any other gainful employment which is inherently incompatible with the official duties of the officer, results in a conflict of interest, or the public officer is mandated to regulate.
Well, you make some argument when you want to compare this with a judge or a magistrate. But you remember, a judge or a magistrate, if you look at their pay, they have what is called an under-practicing allowance. This is to mean that this judge is given the liberty of choosing. If you want to become a judge, if I, for instance, want to become a judge, then I am choosing to take that non-practicing allowance and to wish away the opportunity that I have as a professional of serving or giving or having myself available to the other members of the public who will require my services.
Kenya is yet to achieve the doctor-to-patient ratio of one doctor serving 10,000 patients. Kenya's current doctor-to-patient ratio stands at one doctor serving 17,000 patients.
We are not yet there. We are very far from it. And therefore, the number of doctors, even if we employ all doctors now in the country, whether they are 7,000 or 8,000 trained, we are still not reaching that threshold. So we need all our healthcare providers, both in nursing, clinical officers. There is no cadre that I can tell you has reached that threshold. We are far from it.
Medics argue that it is the ill-equipped public hospitals that lower the quality of healthcare services rather than working at two entities.
If a doctor has no tools of trade, have you given them their tools of trade? If it's a cardiologist, do they have everything? If I need to go to theater and I keep on cancelling my theater list because you have not brought commodity, do you want the doctor to sit there 24 hours? Well, they can save life.
The political system that governs the health sector, they see health as a liability. They are not going to invest. You are not going to have equipments that are working in those facilities. You are going to have a very lean staff because they don't want to pay those salaries. They will not be taking clinicians back to specialize. And so when that need comes and the demand is so high, like in a case of outbreak, we are really going to crumble as a country. So you have quacks opening facilities and they actually get patients. That says something, and not something about the quack. It says something about our health system. It means there is a lot of unmet needs. And there are crooked people who have seen that. They have taken advantage of the unmet needs, and now they are using that to exploit the patients.
With the rising cost of living, the crime rate is also spiking. To ensure you're being treated by a licensed doctor, you are required to follow certain procedures.
Send a text to 20547. You type in P#, the doctor's name. When you send that, it immediately responds and tells you that that doctor is called Dr. So-and-so and is licensed. It will give you the license number. Of course, it will it will blank some of them, but if you are with the doctor, you can confirm those numbers, and it will also tell you whether they are licensed for this year. If it's a health facility, it's the same process, but now you start with a H hash. So for any facility, even for a medical camp, you will just write MC hash, the name of that medical camp, to 20547, and you get.
In Kenya, accessing essential healthcare services can feel like a gamble, especially for the low-income citizens, unsure if they'll receive the care they urgently need. Husna Mohammed, KTN News, Nairobi.